Well, hi, everyone, and good afternoon and happy Tuesday. From the His Health team, we want to thank you so much for joining us for today's His Health webinar contribution. Today's topic is pre-planning for PrEP access and uptake among non-clinical spaces with a special focus on Project Silk, which is a partner of His Health. Project Silk is an innovative program directed towards Black and Latino young MSM and young transgender individuals between the ages of 13 to 29 and their sex partners. Project Silk provides and links patients to medical care, housing and shelter, mental health and substance use counseling, educational assistance, job readiness assistance, dental care, hormone treatment, legal services, leadership training, and more, all while providing a youth-centered and welcoming space for artistic expression. We are so pleased to be joined by the Project Silk team today. Brian Adams is the Clinical Supervisor for HIV STI Testing Operations. Jess Netto is the Director of Youth Programs. Dr. Mackie R. Friedman is Project Silk's primary investigator, and Daphne Beers is a Therapeutic Intervention Specialist. So welcome and thanks for joining us, team.
Thank you.
Wonderful. So these 4 team members will be our presenters for today's webinar. Just a few housekeeping rules. All of the phone lines are muted until dedicated question time, which will happen at about 2:45. We ask that you do not put the call on hold. There'll be dedicated time for questions, and we ask that you just type your questions into the Q&A chat box below, and then we will retrieve those questions and ask them of our wonderful, fabulous panelists. There'll also be a short, hey, Mac, there'll be a short evaluation following the webinar. We'll send you a link, and we would so appreciate it if you could fill it out and let us know how we're doing and how we can improve this experience for you. So before we dive into sharing a lot more about scale-up of PrEP pre-planning at Project Silk, I always like to start these webinars with a bit of an overview about the His Health Project and who we are. So His Health is a cooperative agreement that was funded by the Health Resources Services Administration's HIV/AIDS Bureau. And what it's really meant to do is to engage both healthcare providers and practitioners, both clinical and non-clinical, as well as Black MSM patients in improving dialogue to better accelerate both HIV prevention and care treatment for Black gay men. To that effect, His Health identifies as a united community of advocates and healthcare providers who are thusly passionately committed to raising the standard of care for Black gay men. I think everyone who is joining on this webinar is very much aware of the epidemic amongst this patient community. Our stance and our ethos is that in order to shift the HIV epidemic amongst Black gay men, it cannot be viewed as a singular approach in which the patient is solely responsible. His Health believes that the work we need to do is a shared responsibility of patients, providers, and administrators who are operating at every level of our nation's U.S. healthcare system. We are also very clear about how stigma and racial discrimination and medical mistrust act as tremendous barriers to good healthcare for Black gay men, and we understand that recognizing that is a first step to doing something about it. In order to restore trust, we have got to restore better communication and break down silos so that we can really look at working within a public health sphere that is not only moving forward trying to end the HIV epidemic, but also moving into a public health sphere where HIV-related and race-related health disparities are vigorously addressed to no end. And the only way to do that is if we're talking to each other, sharing good strategies, and doing the work hand in hand. So right now, I think is a really good time to turn it over to the Project Silk team, who will offer a background on PrEP as HIV prevention. Take it away.
All right. Thank you. I'm actually going to toss it over right now to Matt to talk about this part of the background.
Thank you, Brian. So we've got some musical chairs in here right now. Thanks for bearing with us. So I'm going to talk a bit about PrEP. What is pre-exposure prophylaxis? So in 2012, the FDA approved PrEP and that PrEP is tenofovir, for HIV prevention. And some really compelling research on efficacy has shown that PrEP can basically provide 95% efficacy against HIV transmission in HIV-negative individuals. And so that's really exciting, but that is test tube, right? That is when PrEP is taken 100% of the time and fully adherent. And one of the things that's been a challenge for PrEP delivery is how do you make PrEP accessible to populations who may not be interfacing with medical services. And that's one of the things that we are trying to do with Project Silk. So when we talk about efficacy, we're always concerned with that gap between efficacy here at 95% and maybe effectiveness here down on the ground, because everything changes when you move things from that kind of perfect research trial environment to on-the-ground delivery. And right now, community delivery of PrEP is kind of uncharted territory. There aren't a lot of organizations that have provided PrEP to folks that aren't clinically based. And, you know, I think that that's a real challenge for HIV prevention, because there's always been a dichotomy between HIV prevention services, which have sort of historically been offered on the ground through community-based projects since really the late 80s, and care services, which have been offered in clinical environments, you know, since really the early 80s. And part of that has been a funding dichotomy, where the CDC has generally funded prevention services, while HRSA and other mechanisms such as medical billing fund HIV care, right? So you've got Ryan White funding from HRSA that does a lot of the HIV care for populations that don't necessarily have medical insurance. You have things like AIDS drug assistance programs that get funneled through HRSA via Ryan White funding. But from the prevention side, we've been sort of used to CDC funding through state health departments funding HIV prevention projects. And PrEP is a kind of a unique way where maybe we can merge all of that and bring HIV prevention and care together in a more integrated way. But the way that that's been researched has really looked at clinical settings. So we know that we know how to reach communities. We know how to provide services within a community delivery model, and Project Silk is that. It's a recreation-based community health space set up so that people can come in, they can feel engaged, they can dance, they can vogue, they can do things like watch TV, play video games, play cards, have fun, have a good time. They're not coming in for clinical purposes necessarily. They can when they come in, they can ask for services through an electronic tablet system that we have, and they can get services across a broad range: HIV testing, STI testing, social services, mental health care, all of those things they can get. But we're not really a clinical environment. So one of the things that we wanted to do when thinking about PrEP access at Project Silk was try to incorporate how can we do that while maintaining our overall kind of organic, recreation-based sensibility that brings people in and engages them effectively. So that's been kind of our challenge in the planning process, and something that we'll talk about fairly deeply, and something that we hope that other community-based organizations can emulate when they think about how to do this. So I wanted to also, in talking about this kind of efficacy versus effectiveness, talk about some of the things that researchers are finding, even in research protocols based on clinical environments. And even in those situations, they're finding a kind of a gap between what they're hoping for at this 95%, you know, almost perfect HIV prevention characteristic, and what they're seeing on the ground. And so I'm looking at a couple of abstracts from CROI, and some really good work has been published from those abstracts, and those are all available online from that conference. And so from CROI 2016, looking at populations of Black MSM as well as specifically young racial minority MSM, folks who are doing these research trials through the HIV Prevention Trials Network, or HPTN, were finding that adherence was not optimal. So looking at things like 68% adherence in one study, another study showed that adherence above 50% was reported by 85% of folks. So we're already kind of talking about this gap between efficacy at 100% adherence and effectiveness at probably lower adherence levels. And while this was associated with some reduction in HIV incidence, HIV incidence still remained high for Black MSM who are on PrEP, so about 2.9 per 100 person year, so about 2.9 of the cohort every year was still seroconverting while on PrEP, which is a reduction from the 7.7% they were seeing in folks who were not on PrEP, but it's still at really high levels. So I think that in prefacing this discussion, we really have to talk about how can we boost up adherence and make sure that people who are taking PrEP are getting adherence counseling, are getting everything that they need to take PrEP 100% of the time so that they really will be protected when using it. So that's kind of some of the stuff that we're thinking about as we try to roll this out. So all of that being said, I think I'm also going to take a little bit of time right now to talk about, as we discuss rolling out PrEP into our existing model, we're also talking about how was Project Silk set up in the first place? How do we provide the services that we offer right now? And wanting to make sure that every service that we roll out follows the same structure of planning that the Project Silk model relies on. And we can distill that essentially by saying that, that we ask the community what they want. So we conduct really rigorous and consuming, but also quite useful assessments of need in the community. And not only are we asking the community what they need, we're asking how they would like that provided, and really trying to follow that advice and that guidance throughout the process as we roll out that service that's identified by the community. And I think we'll see that when we talk about the mental health piece that we added in later in the project, and when we talk about how we're planning PrEP delivery. So Project Silk was started in 2013, and it resulted from extensive discussions with communities from 2011 to 2012. And those discussions were really based on, first, assessing barriers to HIV and STI testing among specifically young Black, MSM, and trans youth here in Pittsburgh, Pennsylvania. So we conducted focus groups with that group of folks, with the community that we were working with pretty extensively at that point, and got information that really wound up leading us to propose a grant. And that information was based on some sort of gaps that the community was assessing here in Pittsburgh, and those gaps were related to not feeling like there was anywhere for people to go, for young Black MSM, gay and bisexual men, transgender individuals, to go just socially. There's no place that they felt at home, no place that they felt like they could be authentic and be themselves. And, for a couple of different reasons, there aren't a whole lot of places that youth can go and just congregate, but especially places where youth of color can go, and especially places where youth of color who are also sexual gender minorities can go. And so one of the things that they were talking about was, yes, I can go to a clinic, there's HIV services offered here, and we can do that, but we don't feel like necessarily that clinic is for us. We feel like that's just kind of for the larger community, and the hours aren't accessible, location's not necessarily as accessible as it could be, places that are open 9 to 5, we have high school, we have college, we have jobs, we can't necessarily get there during those hours. So one of the things when we proposed that grant was to make sure that we had a place that was accessible, and not only that, a place where folks could come beyond normal business hours to get testing, to get HIV testing, to get STI testing, and to have that be all in one instead of folks having to just go somewhere for an HIV test and go somewhere entirely different for an STI test. And a place that they could choose what test they were getting instead of going somewhere and having someone say, no, you have to get the whole package of every test that we offer, being able to allow people to get what test they wanted at a given time. So we were very conscious of being able to offer not only accessible location, but accessible hours for people at a place that was just for them and where they felt comfortable. And so we continued asking those questions as we got the grant to say, how do we roll this out? How can we, make sure that this place winds up being what you want, by having community forums. So we had community forums every month where we invited 15 to 20 people who were representative of the community for 6 months before we rolled out this project. And then for an additional 3 months before we started offering HIV testing services beyond that. We opened the project, had a space where people could socialize, had structure, had rules, and had hours for it, but didn't offer testing quite yet, so that people could really get a sense of trust in the space, and a sense that their social needs were being met, because that was their primary concern when they came to us. We need a place where we can be ourselves. Now, in addition to that, folks were really talking about how difficult it was to access the social services that they could be authorized to use. So we wanted to make sure that we were offering in-house social services, and people were particularly referencing that gap between HIV positive and HIV negative, so that kind of serostatus gap that's existed since the late 80s around service delivery, especially social service delivery, where folks who are HIV positive sometimes have better access to social services than people who are HIV negative. It provides, some researchers have shown, a perverse disincentive to HIV prevention and to making sure that you're being sexually healthy. When you can get housing if you're HIV positive, but you can't if you're HIV negative, that's a really perverse disincentive for practicing HIV prevention practices. So we wanted to make sure that we were offering all the services, social services like housing, job assistance, employment assistance, education assistance, shelter, food, transportation assistance, to folks regardless of serostatus, and that was one of the very first things that we built into the model. And Jess Netto can talk a little bit about that as well. So that's kind of a brief overview. We've been able to integrate this kind of multi-service approach in a community health space model while still retaining that sense of this is a place where you can be social. You don't have to have any services at all. You can just come and be here. And we thought that if we set it up that way, that people would avail themselves of the services that were there. It was sort of like, if you build this, they will come, and that's what happened. Folks were coming in, they were saying, you know what, actually I do want this service, and then often they would wind up, after meeting someone 2 or 3 times, disclosing HIV status and saying, oh, I'm not actually in care right now, can you help me with that? So that kind of trust building over a long period of time that was reinforced by comments from youth advisory board members and from even before the development of the youth advisory board, these community forums that we held, trying to listen to those, to really listen to their guidance and stay true to the principles that they suggested has always been a model for success in how we roll out the services that we have and how we integrate all those services together into a social space where they feel comfortable. So it's kind of a brief overview of both PrEP and Project Silk and how we've structured it. And with that, I'm going to give the floor over to Jess Netto.
Hey, Jess, can you hear me?
Yes, I can.
Just let me know next slide. I'm on slide number 7. So just let me know if this is the right slide, if I shouldn't be.
I'm going to continue on the discussion from the previous slide, and then I'll roll into the community-driven structures. So as Mac was saying, with the history of our project, the entire premise of this project, including its inception, has focused not only on how to reach allegedly hard-to-reach populations, but how to transform social service provision itself to be relevant and accessible to everyone. So as we continue our services today, that foundation is really how we inform the trajectory of what we provide. So we recognize that providers are responsible to provide quality care and take ownership of the programs that they provide, and they should not operate on the assumption that people are not invested in their own wellness, but instead exactly the opposite. So as Mac described, our recreation-based community health space has these sort of harder outcome objectives to implement structural and behavioral interventions, to routinize testing in creative, innovative ways, and to enhance linkage to and retention to care. However, we also have this underlying harm reduction philosophy that allows for softer outcomes, and we are constantly internally processing how to do those services better, as well as to reach these direct service outcomes as required to assess and provide quality HIV prevention and care services. So what does that mean? We're prioritizing the basic needs service provision as the client has identified themselves. So if people are interested in housing or food or even hormone treatment prior to gaining linkage to HIV care if they test positive, we're going to focus on that and have them define their goal plan for themselves. Privileging those needs over HIV testing outcomes is important to the success of our program. So we focus a lot on life skills groups and healthy relationship building just to promote overall capacity building and decision-making skills within our communities to ensure stability overall. Next slide. So we have a multimodal peer-driven structure approaches. We've established a service provider board and collaborate across different service continuums in the county to focus on basic needs service provision and build community networks that people have, or the individuals we serve have outside of the space. So we have implemented internal volunteer structures where people are able to meet with community stakeholders, network, and also just access services outside of our place-based services themselves. So we have a monthly youth advisory board as well. I do not make any unilateral decisions with programming. We really have member-driven structures, and any changes need to occur through the youth advisory board that meets monthly. And this also serves as a way for people to have civic engagement opportunities and build leadership themselves. So another client-driven structure is our outreach plan. So we have social networking strategy in place for people to identify individuals that are hard to access to get tested, but they also use a variety of venue-based platforms outside the space, whether that be social media platforms or house ball events themselves. They've created really original video PSAs and communication strategy plans that are relevant to the community we serve. Another thing in itself is the organic rapport building and mentorship that happens within the space. So a lot of navigation of structural barriers and access to institutions that are discriminatory or have internal barriers themselves. People are gaining access to those institutions from hearing other individuals in the space talk about their experience. We also prioritize translating narratives to the systems level that we hear within the community we serve as we do service delivery and engagement and retention in those services. Okay, great.
Hi, everyone. My name's Daphne. Like we said before, I'm the Therapeutic Intervention Specialist at Project Silk. So I'm a social worker, and I provide mental health services. I wanted to talk a little bit about, if we go to the next slide, sorry. Thanks. I wanted to talk a little bit about why a community delivery model. Why don't the participants in our programs go to central housing services for housing needs, or the Social Security office for Social Security? Why is that not their first stop? A lot of the folks that we work with have a great deal of mistrust of these larger institutions, as Jess was talking about. When I think of Project Silk's, one of Project Silk's biggest strengths, it's that we've created a structure that normalizes access to these larger institutions. So again, your friend went last week or went last month with a service provider. They know a little bit about how the institution works, and they can go with you. Not every participant at Project Silk needs to have a social services coordinator or a therapist, but might need a friend to just go along with them. So at Silk, part of the strength is that we're creating these natural networks. And the other thing is, by offering these services within the community delivery model, within this recreational space, we're trying to lower the threshold for access to services. So it's not that folks can't go see medical providers, It's that they may feel more supported, more heard, more understood if they are bridging the gap to that medical provider through a space that they already trust. Again, some of these services may be more cost-effective. Often in the beginning, it can be challenging to set up a clinic where an MD comes to your community-based organization once a week or once a month. However, we found that it can be more cost-effective to have peer staff or social workers discussing the need for something like PrEP, for example, rather than having the MD need to do all of that work with each client. We like to say that we're offering options beyond traditional delivery models, and as I'll talk about, it's because the participants are suggesting that that will help them. We can go to the next slide. Oh, the one with the picture on it, sorry, one back. Perfect. I'm going to talk a little bit about what we did with mental health. So originally when Silk was founded and started, we had a lot of folks coming in with social service needs, and we were seeing time and time again people requesting mental health or counseling services, but we didn't have somebody at Silk who was specially trained in that. So when I was brought on in late 2014, we spent a lot of time doing a needs assessment with the youth. We talked with participants about what they want to see, like Mac said, how they want to see those services being implemented. And again, we wanted to just remove as many barriers as we could. So to that end, folks sign a confidentiality statement. We obviously go through what HIPAA means and all of the mandatory reporting requirements, but otherwise, folks don't fill out paperwork. We don't have them fill out extensive forms or anything like that. We're, again, minimizing those barriers to services so that we can focus on what the participant wants to work on. How our services, mental health services, are structured is that folks can participate in a one-on-one environment, or as they like, they can bring in partners, they can bring in friends. And often what we've seen is that youth will bring in their friends and make a referral on their own. In addition, we have groups with topics that are set by the youth, and often we'll have a youth who formally co-facilitates because they've got an idea and they really want to talk about it. And even though we completed this initial needs assessment in 2014, 2015, it's constantly an iterative process, and we continue to get feedback from the advisory board and other folks about this. So I think as we're looking at PrEP and pre-planning for it, we looked a little bit back to how we incorporated the mental health services just to see, can we replicate that model of really asking the community what they want and really hearing from them about what they like, what they don't like, and what they want to change. And I'm going to have Brian take over. Thanks. Musical chairs.
All right, and we're back. All right, if we can go to the next slide, please. All right, so now we're moving on to our process for pre-planning for how to deliver PrEP in this community-based setting. So in order to better understand where the community was or is currently in terms of PrEP, we did a number of assessments using mixed methods, so qualitative and quantitative options. And we really had these three main questions to ask participants. One was whether or not people were just interested in PrEP in general, and then also kind of moving down to that third question, what questions did they have? What barriers were there for those who were interested? What was preventing them from getting on PrEP? And then also that second question, what would people want to see if they were interested in PrEP? Where would they want to go for it? Would Silk be an appropriate place in their minds for accessing PrEP? So in our mixed methods, we did a couple of things. First, we asked the Youth Advisory Board how they felt about accessing PrEP. We asked them how they felt about PrEP in general, but also accessing PrEP at Silk. And so once we ran that past the Youth Advisory Board and kind of got the okay from them to do this process, we then developed a survey that we passed out, that we kind of used or delivered with our intake survey. So whenever someone comes to Silk for the first time during any given day, they sign in, and we have a form where they can, it's electronic, where they can indicate any services that they want, as well as other things as well. And then at the end of that intake survey, we added this PrEP survey to ask basic questions. Are you interested in PrEP? If not, why not? We asked about health insurance. We asked, and it was all anonymous. It was not attached to their sign-in. So we were not able to connect the two. We also did a couple informal focus groups. We had medical professionals come in and talk and answer questions about PrEP, as well as ask the youth what they thought about PrEP and any questions that they may have had. And so if we can go to the next slide. So looking back at that survey, we had it up for about a month. We got almost 100 responses. And about 22% said that they were potentially interested in taking PrEP, either by saying that they definitely wanted to, or that they weren't really sure. We also thought it was interesting to note that a little over a quarter of the respondents who said that they were not interested also said that they didn't think that they were at risk for contracting HIV, which could indicate a barrier in terms of education about risk and risk-taking, but although some of those people could very well may not be at risk, they could not be sexually active or things like that. That 20% of people who said that they were interested may also seem a little bit low, but again, we estimate about 20% of people who come to Silk are already HIV positive, and so for them, PrEP would not be appropriate. And in addition, we do work with youth, and not all of them are sexually active. So we feel that 22% is actually a pretty decent number. And then moving on to the community acceptability, over half the respondents said that they felt that PrEP delivery at Silk would be a good idea. As you can see, about a little over 40% said yes, and then a little under 10 said that they weren't sure. And so we felt that was a good baseline. And an indication that moving forward would be something of interest. Some other interesting things from that survey, while discussing this whole process with a couple medical professionals who do PrEP services, one of the big barriers is health insurance. But oddly enough, the barrier is that if you have health insurance, the whole process becomes much more complicated. For individuals who are not insured, there are a number of barriers that kind of get removed, and the process becomes easier in terms of helping people to get on the PrEP. And so there was a thought that perhaps our community, that the community that we serve, would not necessarily have health insurance, and so there would be that barrier would be removed, and we could easily move into kind of PrEP delivery in this community model. However, what we found was that about 86% of the people who said that they were interested in PrEP actually had health insurance, and about half of those people had some form of Medicaid. So that was not something that we were expecting, and something that we'll have to work with while moving forward. And yeah, that's all that we had about the survey. So I'm going to hand it over to Mac to talk about some of the more qualitative findings on the next slide.
You know, you would think that we would have just moved the computer around rather than all of us jumping over each other, but we can pre-plan all we want with the community, but with ourselves, much more difficult. So I'm going to talk a little bit about some of the qualitative findings that we are analyzing here before setting up PrEP delivery at Silk. So some of these include, and so we had discussions with Youth Advisory Board, as Brian mentioned. We also had a community forum, and then a couple of additional discussions with health providers who came while Silk had open hours and just had kind of open-ended conversations. So we've pulled together information from all of those meetings, and they've really helped us kind of understand the complexity in what we're looking to try to achieve here, as well as making sure that we're able to explore some of the avenues that they've suggested to make it as successful as possible, just kind of following these models that Brian and Jess and Daphne have talked about already. So I think I'm going to just present some of the most interesting findings here, and so the slide shows some quotes from people. The first, give people more education about PrEP in a way that's interesting to them, so really speaking to the need for more education about PrEP in a way that's accessible and engaging. And then the second quote, I think people aren't using it because it's not provided here, because it's not here. Recognizing that there's a real gap between clinical and community delivery of PrEP, at least here in Pittsburgh, but we think probably nationwide too. And, you know, some kind of basic logistical questions about, taking PrEP. I have problems swallowing pills, you know, and is the PrEP a big pill? So kind of an easy fear to deal with, but also, you know, not necessarily. If you really don't like pills, right now there's no alternative. There soon will be with injectables. You know, so I think those are three, like, quotes from, directly from individuals. And then I've got some thematic information that I think is also really relevant here. So what are the side effects? That was a big question that people asked. And, you know, those side effects are real beyond things like nausea, occasional headaches, things like that. Bone density loss or bone mineral density loss is a real concern. And that's been shown even among youth populations. Most recently, and again, I'm citing Croy here, it looks as though that bone mineral density loss is reversible after you stop taking PrEP, but it's there and it's real, especially for people who are growing. So one of the things that researchers have contextualized that finding with is saying, well, PrEP is supposed to be time limited, and that brings me to the next kind of big theme that's come up in these focus groups and community discussions is, how long do I have to take it? You know, and that's a big question, right? If we're talking about delivering PrEP here, what are we saying? Well, we want you to take this as long as you're still a young black MSM, as long as you're still a black MSM. What's the public health message here for PrEP? So that was such a great and important question, and I think we've all found ourselves a little unprepared for it, right? Like, how long are you supposed to use condoms? Well, as long as you take sexual risks. Are we saying the same thing about PrEP? What are we asking a 15, 16, 17, 18-year-old kid to think about as they start taking PrEP? For how long? For the rest of their lives? So that's never been the intention, I think, of PrEP delivery, right? It's always supposed to be kind of a time-limited approach during high-risk periods in one's life. But I don't think we have a real good set statement from a public health perspective how you answer that question to, you know, a youth who really wants to know. And I think that there are also some behavioral issues that are in play here too, as you think about this question a little bit more deeply. And we've seen this among people that we've talked to, and also at CROI in reports. You know, there are also anecdotal reports from doctors across the country where folks will be on PrEP, they'll take PrEP, they'll be adherent, but then something in their insurance changes, or they'll move to a different state and they'll have to kind of switch accounts over, where they don't get PrEP for a period of time, kind of like fade out, don't take it quite as much as before, or don't take it at all. But if that was their sexual health safety method, and now they're not using it anymore, they're kind of back to default. So we really have to start all over again with sexual health practices, with condom use, with safer sex negotiation, seropositioning, all of those harm reduction techniques. Maybe someone who's taken PrEP from the get-go and hasn't gotten those condom negotiation messages and those behavioral approaches is going to have a harder time trying to negotiate safety without PrEP when they're so used to taking PrEP and having that be their safety. So I think that's a real concern as well that we need to face up to when we start talking about this. When do you stop? When you do stop, what do you do then? When do you get back on? Is this something that's kind of an intermittent thing? We've also talked to folks who are sex workers who say, well, I'm just going to, I'm interested in this, but I'm probably only going to take this for my sex work, which is on weekends. So I think that's another approach that we have to be mindful of. What's the consumer saying about when they want to take in, when they think their highest risks are? And then what do we do for those other time periods, right? Yes, tenofovir can still exist in your system, but you might not have levels that are going to be totally protective against HIV transmission. And I think that's the case with less adherence as well. As adherence falls down, you're also seeing effectiveness fall down on a linear slope as well. So that's something that we need to kind of keep talking about. How do we boost up that adherence? Another important question for us has been, what if I'm not 18 yet? I'm 16, I'm 15, I'm 16 years old. How can I find a doctor to prescribe this to me? Well, the FDA doesn't currently approve it for people who are younger than 18, probably because of that bone mineral density situation. That may be changing soon, we'll see. But for the moment, unless you're willing as a doctor to provide PrEP off-label to somebody who's under 18, your options are really limited. So I think that maybe we can kind of counteract some of those falling off PrEP without earlier sexual health counseling by providing really strong sexual health counseling and really strong behavioral interventions to people before the age of 18, before they can be eligible to take PrEP, and see if that kind of can last them through those periods maybe after they're 18 and PrEP use can fall off. Some other good things came up from these focus groups related to social marketing and media. How do we promote this? If we're going to do this, how do we promote this successfully? Maybe we should have a ball. We can have a ball that's kind of focused on, oh, you can get PrEP at Silk, and this is a ball that's going to kind of market that to people. And using social media to kind of get the word out. So really good advice around that. And so that's been consistent with how things have worked for us in the past by really getting youth involved in that media and marketing and delivery messaging. And then, the other really important question that we've received is, when do you offer it? Do we offer PrEP during typical business hours at Silk, or do we have it during a day that we're typically closed? So like a Saturday, for instance, or a Sunday, and have a PrEP-only day so people can go there and also get support from each other maybe, have some kind of organic support groups that are coming up around PrEP use and adherence. So all of those things have come up, and we're just kind of going through those results and trying to figure out a workable delivery model and maybe kind of a combination of approaches that can reach everybody who's interested. And I think that the other thing that we should also talk about is we've assessed kind of barriers and ideas from a medical perspective as well, talking to clinics and different providers about what they would like to see in a community delivery model and really trying to work with them. And Brian talked a little bit about some of the issues related to to insurance versus not insurance. Sometimes it's actually easier to not be insured because you can have medical software for EMRs donated to you. But there are also more kind of other logistical issues that we wouldn't know about unless we talk to these clinics, and that's related to floating malpractice insurance. Can we make sure that the doctors who are there and providing PrEP on site are insured to do that? So that's, you know, hugely important, of course. Creatinine testing. Can we find alternative ways to get creatinine testing? For instance, if somebody isn't insured, how do we cover creatinine tests? It's only $10 a test, but if you're giving PrEP to 100 people and they're each getting creatinine testing 3 times a week, that adds up. So making sure that we have ways to, if we can't bill for it, ways to fund it. If we're talking about doing kind of rotating clinicians so that we don't abuse, like, you know, one poor clinician who we're asking to come every couple of weeks to provide PrEP, to clients, how do we minimize their time? And one of the things that we thought about is rotating physicians from different clinics to also provide a different choice for clients, because that's one thing that we really like to do. We like to be able to encourage rapport with people and allow them to choose who they want to be seen by. But if you do that, you also have to have EMRs that speak to each other, because if you're here one week, not here the next, but you still want to see a doctor, but that doctor's not affiliated with this health system, how can you access that information? So how can you get an EMR that talks to another health system? So those are all things we're also trying to work through here. There's also billability on our end, and Xavier Robinson has talked a little bit about that in the project self-sustainability piece that he's presenting on his health, is that maybe this is a way for community-based organizations to kind of edge their way into medical billing. So HIV prevention medical billing is something that is kind of a new frontier, and PrEP allows us to explore a little bit of that too. But there's also a challenge with installing a whole new billing structure into pre-existing administration. And then, you know, as we talked about physician time and how to reduce that, you know, and this was brought up before by Daphne, is how to make sure that we can do everything, or by Jeff, how do we make sure that we can limit the time the medical provider has to give us, if they're volunteering, for instance, so we can do everything we can on the front end to do that education, even do blood draws, do some of that phlebotomy, make sure that everything's set. We can do the HIV STI testing, make sure someone is eligible and not actually HIV positive and they didn't know it, or has untreated STIs. You know, we want to make sure we can really minimize that time on the physician end. And so we're exploring some technologies to do that as well, to allow physicians to maybe offer PrEP remotely. And then another thing that community brought up is PrEP representatives. So we had people who were on PrEP who were willing to be sort of PrEP ambassadors or PrEP representatives to other folks who were interested in taking it. So we think that that will be also integral to the model that we wind up kind of rolling out. And I think that's most of the information that I have here. I also want to say that, you know, talking about condoms is still really important, and that we know that when rolling out PrEP delivery, we can't absolve ourselves from having larger sexual health counseling discussions, including condom negotiation and behavioral health risks that are associated not only with lower adherence to PrEP, but also with other STIs. Even if you're taking PrEP 100% of the time, you're not protected against syphilis, gonorrhea, et cetera, and syphilis is rising in our state and in our county. So we have to be really cognizant of that when talking with people about PrEP delivery. And we also know that PrEP will not solve your housing concerns. And so continuing to provide the holistic health model that we feel really proud of is also going to be integral to the PrEP rollout. And so, I'm sorry, you can go ahead and skip ahead a bit. We talked about the Ask a Doctor focus group. I mentioned some of the results there, and this is just a kind of picture of that, and it happened before a ball. So this is a really tight model of how we're envisioning PrEP delivery, and I'm going to pass this along again to people who are fighting over it.
Okay.
Hi again. Brian and I developed this model, and we wanted to talk a little bit about it because we wanted to envision how a client or a participant at Silk would navigate through the process of getting it. So again, the client is interested in PrEP, expresses this wish or this thought or this harebrained idea to a Silk staff member, and then what happens after that. So we're trying to figure out from the client's perspective how this all would happen.
Yeah, so basically in this model, you kind of, at the top are just kind of the ideas of how that idea may come to fruition through advertising or PSAs that our staff may or youth may create, kind of like those representatives, or other staff promotional materials to get the participant interested in PrEP, and then kind of going down into the middle of that diagram of the model, you start with that HIV test, because if an individual is positive, they aren't going to be eligible for PrEP, and a whole new protocol comes into place for linkage to care. Once the HIV test comes back negative, you can kind of move forward with talking about behaviors or the general appropriateness of PrEP, and then kind of talk about HIV prevention and general STI prevention education, including condoms and other activities, and then also scheduling appointments for the other testing and also the prescription.
Mm-hmm. Can I just jump in
here?
I wanted to highlight the fact that with these folks, as with any folks who might be eligible for PrEP, these conversations around discussing risk behaviors and discussing sexual health education are really, really critical, because a lot of the times folks may misassess their own risk. There's quite a few people who may or may not really need PrEP, but who, because of anxiety or other worries, really think they need to be on it right away, so it's kind of figuring out whether they're really appropriate for that. And there's a lot of folks who really are exactly the target market for PrEP, but who think that they, because of their sexual health practices or the kinds of partners they're having, they really underestimate their risk. So.
Yep. So we're kind of down near the bottom of this model now. So we've scheduled that appointment for them at a PrEP clinic. We've helped them complete their testing form, the waiver of confidentiality, and then here's where it gets kind of tricky, because this is where the insurance comes in. Like what do you do in each situation? So if they have insurance, hopefully you can help them navigate getting on PrEP through their insurance, and hopefully there isn't some crazy deductible. If there is insurance but they can't use it, so for example, if they're on their parents' insurance but they don't want their parents to know that they're on PrEP, then you can kind of get into a hairy situation there, as well. And then also no insurance. There are a number of options in any of these situations. You can try and get them onto Medicaid. Gilead has a program. I think it's particularly for people who are uninsured or underinsured, I believe, and then or just general insurance.
So either way, we encourage folks to fill out the paperwork with Gilead for the assistance program, because even if they do have insurance, they may be able to get some of the co-pays covered. We can go to the next slide. Great. Okay. So once the clinic appointment is scheduled, the participant needs to get there. Sometimes they may go with a Project Silk staff member or a peer, or even a friend might go with them to the appointment. They meet with the medical doctor and make sure that they order a creatinine test, as well as any other testing that the doc wants to order at that time. Again, we can offer to escort them to that appointment, making sure their kidneys are okay. In some situations, they'll need to discuss alternative options, but that's quite rare. So we can proceed with paperwork and with the prescription here.
Yep.
And again, once we get to this last tree at the end, kind of, again, it's a process of follow-up education, continued HIV testing, other STI testing, and sort of sexual health discussions with the client and just supporting them in making sure that they're taking ownership and taking care of their own health.
Yeah, we kind of see PrEP delivery in the same way that we see routine HIV testing, and that it's a consistent opportunity to have these conversations about sex and sexual risk with our youth, and make sure that conversation is always geared towards that risk reduction ideology, whether that is through PrEP use or condom use, or hopefully both. Or abstinence, whatever options they feel is best for them at the time.
Mm-hmm. Yeah.
So, okay, so next slide.
Do you want to just change the computer?
Oh, it's an everybody slide. So, just to kind of start wrapping up, we wanted to bring back those HIS Health declarative statements. There are 5 of them, and we believe that both through our presentation, but also through the work that we do, we kind of, we agree with all 5, but we can kind of show that at least a couple of them are very much present in our work. Particularly, I feel that that second one, that Black MSM are not hard to reach, but rather are eager to utilize assistance in spaces where they receive culturally effective care and treatment and preventative services. Like that's what we do at Silk, and I think that in moving forward with any sort of process, whether that's this pre-planning that we're doing or offering PrEP as a practice, I think that keeping that in mind, that if you kind of what Mac was saying earlier, if you build it, they will come. I think that is what Silk has really shown, both for us as public health practitioners, but also for the general community.
Mm-hmm. And I would just add that just the HIV service continuum in general, a lot of the feedback we get from the clients is that there's this overemphasis on their risk behaviors, which sort of pathologizes social problems on the individual. So we're constantly just assessing how can we change the social determinants, the social problems, how can we affect systems level change and cultural norms so that people are able to access the spaces they need and reach services in the way that is best fitted towards them.
So if we can just go to that last, or the next slide. So this is kind of going along those same lines, talking about why pre-planning is necessary. I mean, first of all, you're asking the community what they want, and that's the best way to make sure that your programs and or anything, to be honest, is geared towards that community. You can make sure that your approach is acceptable to them and is created in a way that they'll be excited to use it. And if you may be able to figure out, we think this is a great idea. However, the community says no, that either that's awful, or you're explaining it in the wrong way, and so you aren't going to get anybody to take this up. And so this process has been really important in terms of understanding what the community wants, and also how best to reach them. And kind of what Daphne was talking about earlier, that we've done this process before, both with Silk in general, with our mental health services, and time and time again, it's been invaluable in helping us to create programs that were both culturally appropriate, but also highly desired by our youth. kind of going along the lines of that third bullet, that we were increasing the uptake of services. Another thing that we felt that was important was was our logistical challenges. This process helped us to identify and work through a number of them. We've kind of talked about a couple of them in this process, such as health insurance and how do you navigate that? How do you navigate multiple EMR systems that don't necessarily talk to one another? How do you try not to tax one specific MD by sending everyone to them every other week? And so some of those challenges, some of those challenges may be individual, based on one specific organization, such as, so for example, is in a mixed-use building, how do you allow for a clinic-type atmosphere while there's a travel agency next door? And then some other challenges may be more universal, such as that health insurance navigation issue. And so the pre-planning process in and of itself is very important for understanding, again, both what the community wants, but also what sorts of struggles are you going to encounter while trying to implement something, especially something as relatively new to the field as PrEP delivery. So with that, we can go to the next slide. All right, and so that's all we have. So if there are any questions, we're happy to answer those now.
Awesome. Great job, team, and thank you so much again for your time and also just talking about how thorough and detailed your process is with assessing and talking very, specifically and intimately with the community to really assess what the needs are. Is there actually a need, and how do you want this information and this resource to be delivered? I think all of those are sort of the tenements of offering care and services that are rooted and steeped in cultural humility. So we want to thank you so much, and we have lots of participants and lots of questions. We're a little bit over time, but I want to see how many I can get to here. First question, we have a participant who asked who provides funding from Project Silk?
Who wants to answer that one?
Anybody?
So we were originally funded by the CDC as a demonstration project. After the 3 years as an evaluation project under the University of Pittsburgh, we have transitioned to a community-based organization, Community Human Services. We're currently funded by the Department of Health, and we are working on a sequestration plan to become sustainable through a diversification of funds. So what that looks like in the future, we're not sure, but we're working with Gilead, we're working with local foundations and the Department of Health.
Awesome. Thank you. Another listener has a question. First, they say, really excellent job and great presentation. This has to do with Mac's comment around PrEP as a gateway for billing and reimbursement. So I don't know if Mac wants to answer, but we can punt it to anyone. They said billing and reimbursement is challenging, particularly for community-based organizations who have not done this before. Are you all exploring other options, such as partnerships with other stakeholders who can offer PrEP access on site, but take on the administrative burden and sort of lift with regard to billing and reimbursement?
Joy?
I will chime in a little bit on that. So I think with the medical billing structures, it would be components of each position, and that would serve as one form of funding. However, we would be reaching out and creating networks with other institutions who already have those systems in place. We have a couple institutions that had offered support and training and technical assistance on how to establish billing structures, but we also already have them existent within our agency for mental health. So it's transferable in some ways to a lot of the other medical components.
Well, another question around PrEP education, specifically injectable PrEP. We have a listener who wants to know, what is your messaging or education around injectable PrEP, specifically how often is it recommended that it should be taken?
That's a you question.
Right, thanks. I can take that, and the answer right now is 0. It's null, because it's, at least in Pittsburgh, that's not really being offered. So until that starts to really gain traction here, we're not talking about it. We're saying, hey, this might be an option for the future, but that's all we're saying.
Mm-hmm. More on the question around education around PrEP. They want to know, one participant wants to know what are the recurring questions that come up around PrEP. And I know that you all spoke about a few in terms of dosage, et cetera, but they wanted to know if there's anything else that you all can think about that comes up a lot amongst this particular patient community.
I think that dosage one was the one that I know I've heard multiple times, and in many forms too. There have been a couple where it's like, how long do I need to take it before I see the effects? If I miss a dose, what happens? I'm trying to remember. There was one very adamant question from one of our Ask a Doctor sections, but I can't remember. It was along those lines, basically like if I'm on PrEP and then I get HIV, can I sue someone? I think that was one of the ones. And yeah.
Yeah, I think a lot of the questions, and this goes back to our overall approach of just sexual wellness and holistic approach to sexual wellness. A lot of the questions are about how to navigate life in general. So how do I go to the pharmacy and access a prescription? How do I go to a doctor and establish a PCP? So some of them are PrEP specific, but a lot of it is also just those life skills building questions as well.
Mm-hmm. And it sounds like, too, that opportunity to sort of offer some insurance education. This could be, cannot at all speak for your patients, don't ever want to, but that this could be a sort of a new advent or forward for some folks who traditionally just have not held health insurance themselves. So it seems like there might be a host of questions around that as well. Mac, I don't know if you wanted to add to that as well.
Yeah, I was going to say that our state's AIDS drug assistance program is talking about potentially offering assistance to PrEP, to users of PrEP. And so that's going to be another one of our kind of navigation assistance techniques if that winds up going through. It's folks who haven't obviously interfaced with the ADAP program in Pennsylvania are going to need help kind of setting that up and interfacing. And I think what Jess is saying about just general interfacing with bureaucracy and structure, medical structure, is something that no standard 18-year-old is usually very good at and has a lot of questions about. It's hard enough for adults to deal with, much less somebody who's never dealt with that stuff on their own.
A few more questions. So continuing around the questions that patients might have around PrEP, one listener has a specific question around cost for PrEP. They ask, how do you demystify the payment process for PrEP without scaring patients off? Because we all know that health insurance payment is, complicated. So wondering sort of what are some of your strategies when talking to potential PrEP candidates about the cost? What kind of things do they ask?
I can talk a little bit about this. I think, well,
yes.
Maybe, I don't know.
There we go.
I don't know if it matters how much you can see me, but one of the things that I've talked with some folks about is waiting and seeing. I think that is a really frustrating and challenging thing for a lot of people to do. I think just like many other medical procedures, whether that's from a regular PCP appointment all the way to some of our folks, genderqueer, trans folks who are talking about hormones or sex reassignment surgery or gender-confirming surgery, again, I think they're quite used to not knowing what things are going to be covered. This is frustrating, and it involves a lot, it sort of necessitates a lot of advocacy on our end for figuring out whether that's, calling Gilead and figuring out exactly which copays they can, the participants eligible to have covered, or a lot of the stuff I've done before with a couple of clients is really just drilling down and calling them the number on the back of their insurance card with them, trying to say, saying I don't know and saying it probably will change month to month, but I'm here for you, I'm supporting you, we're going to work on it together, and together we're going to find out the answer. I think that that's been the most
effective and the most honest answer, because I really don't know, and even if I compile a list of every single insurance and what they cover and it's going to change next week. So so really admitting that and being honest with them about that and then being able to move forward.
Thanks, Daphne. Last question, I feel like we could talk forever and ever, is around assessment of someone's readiness for PrEP. And I think you guys do a lot of great work around sort of assessment for readiness for a host of sexual health services. So PrEP, you know, is definitely being heavily promoted for Black communities, Black MSM patient communities. But we all know that this is a myriad, varied, diverse community like any other patient community, and PrEP is not for everyone. What is your process for assessing someone's candidacy and readiness to begin a PrEP regimen? With full understanding that you all are not necessarily ensconced in that right now because you're not offering PrEP on site, but I think this is a question about sort of, if we're talking about pre-planning, what are some of your preliminary thoughts or suggestions around doing that?
I think for me, I think back to, you know, any general HIV counseling session that I do, where I'm going through a checklist of sexual risk and sexual activity, trying to understand what sorts of risk that individual may face. And I think that's number one. You know, having an understanding of whether or not they actually are at risk. Number two is, are they prepared to take a pill every day? PrEP, in theory, may sound great. Okay, I can just take a pill every day and reduce my risk of infection. But when it comes to practice, like, is that individual going to really be able to take that pill every day? Are they going to? I think sometimes it make them down to stable housing. Are they able to have a routine? Are they comfortable swallowing pills? Like that was another barrier that we heard, especially during this pre-planning. So having that discussion about you know, what sure, PrEP can do X, Y, and Z, but are you prepared to do these steps in order to make it work? Because the last thing that we want is to say, okay, well, you're at risk, and so here's a prescription, and then they run off and take the pill once a week and think that they're protected when in fact they're not. So I think that's, for me, those are the two biggest things that I want to make sure before recommending that someone moves into a PrEP regimen. Any other?
I would say just providing as much education as possible, and then from a harm reduction perspective, really trying to allow the participant themselves to make those decisions. I think, like Mac had said before, if condom use is working for them, not discouraging, just because we have this new model which might be really effective for this person, doesn't mean that their current method, they should throw it out. Whether it's condoms or, you know, testing and taking a really detailed sexual history and electing not to use condoms, or PrEP, whatever it is that's working for them currently, if it's working for them, allowing the participant to self-determine and really make those choices, while providing the best, most scientifically updated information that we can. Really, and I think part of that is assessing, is the participant able to make the best decisions, and how can we support them in strengthening that? So.
Awesome. Well, yeah, we're about 15 minutes past the hour, and the time always flies with my Pittsburgh folks. So we want to thank you so much for joining us, and thank you all also as well on the webinar. We'll be sending out the PowerPoint slide deck as well as the evaluation survey within the next 2 days. We also invite you to engage with Project Silk on their social media. I know you guys are on Instagram and Facebook because we follow you and post photos up there. I didn't know if you had any other social media that you want to plug now.
I don't think so.
Awesome. And His Health also has a presence on Facebook, Twitter, Instagram, and we also have a LinkedIn page. And we love hearing from providers. So please feel free to reach out to us. If you have other questions, you can always email me directly at hishealth@nasdaq.org. And our next webinar will be coming up next week as well. We'll be talking about some of our focus groups with providers and providing a bit of a report out around that. So please feel free to sign up for that. We want to thank you all again out there, folks at Pittsburgh. Thanks for joining us, and we will be in touch again soon. To everyone who's joined, have a great afternoon and take care. Thanks. Bye.